To our last session of the series Stimulant Health Matters. My name is Maureen Oscadal. I'm a registered nurse. I work with ADAI as a nurse care manager with the State Opioid Response Training Team. And this is the Stimulant Health Matters series, and we are in the third of 3 sessions. Next slide. And just a little bit of Zoom housekeeping, some things to call out. Today we are both recording this call. We will be posting this recording to the website learnabouttreatment.org. We will share the slides and the recording in a follow-up email with you all as well. But just so you all are aware, the recording will be posted publicly. Please mute yourself when you're not speaking. We're going to save questions till the end, but as questions come up, please feel free to put them in the chat, and I will bring them to our presenter during the Q&A portion. And if you have any issues, please go ahead and put any questions or concerns into the chat, and folks from ADAI can help you out. Next slide. And so I would like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the Indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our Indigenous neighbors. Next slide. So again, just to orient you all to where we were and where we are, this was a 3-part series focusing on supporting the health of people who use stimulants, specifically methamphetamine in this context. And we've talked about mental health concerns, we've talked about skin and wound care, and today we're talking about cardiovascular care. And we have an expert from Harborview Medical Center in Seattle, Washington, Dr. Danee Hidano, who will be sharing her expertise as a cardiologist and talking to us about cardiovascular concerns and interventions for folks who use methamphetamine. Next slide. And with that, I'm going to hand it over to Dr. Hidano. Thank you so much for being here. We look forward to your presentation.
Thank you so much, Maureen, and to ADAI for having me invited here to speak to you today about the cardiac effects of stimulant use. I understand that this is a broad audience, and so I've tried to put things in for clinicians and non-clinicians alike. I am a cardiologist. I am not addiction medicine trained, and so I am going to try my best to speak to both the cardiac and addiction issues throughout this talk to just sort of highlight how overlapped our specialties can be. But very much acknowledging that this is a broad audience full of interdisciplinary folks, and I really appreciate all of you being here today. So I do not have any relevant disclosures relevant to this talk. The objectives of this hour are going to be to increase the awareness of stimulant effects on the heart, identify cardiac emergencies that require immediate action by anyone who might encounter a person experiencing such emergency. Number 3 is to review chronic cardiac diseases that we frequently see in association with methamphetamine use, and to also highlight and promote interdisciplinary care for this complex disease. So to start, let's talk about the effects of stimulant use on the heart. So just to call out that more and more, I think it is recognized that there is a huge overlap between substance use and cardiology. Our focus today is going to be on stimulant use in particular. And the reason why you have a cardiologist invited to speak to you today is because cardiovascular disease is actually the 2nd leading cause of death in people who use stimulants. And this is following overdose. And then number 3 is trauma and accidents. Cardiovascular disease, as I've alluded to, can involve either cardiac emergencies and also chronic heart disease. And so we will touch on most of these conditions today in this next hour. And so let's delve right into it. Stimulants damage the heart through multiple mechanisms. These figures are mainly to just demonstrate the complexity of the pathobiology that many basic scientists are researching to try and figure out the different inflammatory pathways that are triggered by methamphetamine use and how that leads to cardiac disease. The pathobiology is not necessarily the focus of this talk, but I think just to show that methamphetamine does cause a lot of chronic inflammation in the heart, which can accelerate a lot of chronic diseases. In addition, there is the known sympathetic activation of the heart that can lead to chronic stress on the cardiovascular system. So to hone in a little bit more on that idea, stimulants really cause what's called sympathetic overdrive, meaning they acutely can really raise the blood pressure and heart rate, sometimes to very dangerous and life-threatening levels. When this happens, those can precipitate cardiac emergencies, things like cardiac arrest or cardiac sudden death, things like heart attacks or strokes, and also tearing of the major arteries or blood vessels in the body. And the medical term for that is aortic dissection. Over a longer period of time of repeated use, ongoing or chronic sympathetic activation can also lead to compromised heart function, things like accelerated heart disease and heart failure, elevated pressures in the lungs, all of which we will get to as well. So if you take nothing else away from this talk, I think I really want to highlight that anyone and everyone should be on the lookout for patients who are experiencing a medical emergency that may be related to their stimulant use. These are just a list of things that I think are really important to have a high suspicion for. So things like people who are not responding to you, meaning they're unconscious, they're not breathing. If you try and feel their pulse, you don't feel a heartbeat. Anyone endorsing severe chest pain, particularly if it's radiating to their jaw, their arm, or their back. Difficulty breathing, trouble speaking, thinking, or moving, or if you notice that half of their face is drooping. If anyone has significantly deranged vital signs, so blood pressure, heart rate, oxygen level, if someone's feeling dizzy or feeling like they might pass out, or if anyone's endorsing just a very rapid pulse and feeling unwell. These are all reasons to call 911 and get that person help right away. So let's go through a few cases, just sort of highlighting some of those pathologies and also warning symptoms that I just spoke about. The first patient case that I'll highlight is a 24-year-old man with known stimulant use disorder who's found minimally responsive in the morning. His friends report he had been using from a new batch of methamphetamine just the night before. His respiratory rate was slow at only 6 breaths per minute. He appeared pale and he had bluish discoloration around his lips. His pupils were pinpoint and he looked diaphoretic or sweaty. His friends who were with him administered intranasal Narcan, which seemed to help initially, but within a couple minutes, his breathing slowed again, and they were already in the process of calling 911. I want to highlight about this case. So this patient has known stimulant use disorder, but notably no known opiate use disorder. However, the underlying portions of this case are concerning for opiate overdose, including cyanosis, low respiratory rate, and the fact that in the history he's using from a new batch of methamphetamine, which raises the concern that there could be new contamination. So I just wanted to show just a quick slide of data that just shows that stimulant use or stimulant overdose-related deaths are certainly on the rise. You can see that there's been a significant increase since 2015. And in 2022 alone, there were almost 60,000 stimulant-related overdoses. And I think what's really shocking to me is that 70% of those overdoses involved fentanyl. And 30% did not. But essentially, harm reduction is very key in avoiding overdose-related deaths, even in patients who tell you they don't intentionally use opiates. And I think that this statistic is really scary, and I think it's important to continue educating our patients about just having Narcan and when to use it. They may not need it on themselves, but they may need it for a friend one day. And so just making sure that we are speaking to our patients about this, even in people who primarily only use stimulant use. I also wanted to highlight that combined opiate and stimulant overdose is the most lethal type of overdose. This is data that's from King County from our Medic One research group. They showed that in the time period from 2015 to 2021, there was nearly a 4-fold increase in combined opiate stimulant overdose, meaning this is something that we're seeing a lot more and more. And like I mentioned, they have the worst survival outcomes as compared to opiate alone or stimulant alone related overdose. And so their survival to hospital discharge is 10%, as opposed to closer to 20% for either opiate or stimulant overdose. Stimulant use causes chronic heart disease, and so part of the theory for why patients don't do as well with a stimulant-related overdose is perhaps because they do have underlying chronic heart disease. Stimulant-only arrest compared to opiate-only arrest, they had more favorable characteristics, meaning their arrest was more likely to be witnessed, occur in a public location, and present with a shockable rhythm. And so ordinarily, you would expect that stimulant-only cardiac arrest may do better. This, however, was not seen, and their outcomes are just as poor as opiate-only overdose, which again highlights that there is probably this underplay of like underlying chronic heart disease. This has been shown as well on autopsy studies. So people who actually did not die of a primary cardiac cause, they ended up doing autopsy on over 900 people. They were pretty young, so in their 30s, 80% were male, yet cardiac disease was highly prevalent in this cohort. 26% had enlarged hearts, almost 20% had severe coronary artery disease, and 20% had fibrosis or scarring of the heart. And this is, from a cardiology perspective, this is extremely young to have that degree of pathology. And so all of these things sort of suggest and support the fact that people who use stimulants have often moderate to severe underlying heart disease. Moving on to our next case, this is a 39-year-old woman who is found unconscious on the floor in her apartment by her partner after recent cocaine and heroin use. She was noted to not be breathing. He called 911, administered Narcan, and started CPR as instructed. EMS arrived, and this was the patient's rhythm, and she was noted to be pulseless. They applied pads to her chest and were able to defibrillate her heart and restore a normal heart rhythm. The features of this case are that I wanted to highlight that we should all be on the lookout for cardiac arrest. So again, if someone is unresponsive, if you can't feel a pulse, if they don't appear to be breathing, this is a medical emergency and this person needs help right away. The first thing to do is, if you're alone, is to call 911 and get them on the phone to get EMS deployed to that location. And the second thing is to start CPR as soon as possible. So these are really the things that we should be focused on. If you have a second person and if you're in a public location where there is an AED or an automatic defibrillator present, certainly having someone grab that for you and apply the pads to the chest and following the prompts as necessary can be very helpful and life-saving as well. Just a quick reminder that CPR, good quality CPR, is 100 to 120 compressions per minute. There are Spotify playlists with all sorts of songs that you can keep in your mind when you're doing compressions to make sure that you are compressing fast enough. And also the distance that you should be pushing down on the sternum is about 2 inches. And then that's just a picture of an AED. If you've ever gone to like a sports stadium or any kind of public location, you've probably seen these AEDs in various locations. And so this is what they are used for. So returning back to our patient who presented with cardiac arrest, she had her heart rhythm restored after a few rounds of CPR and early defibrillation by EMS. She was intubated in the field and then subsequently brought to the hospital. Her vital signs and labs were initially unremarkable, but she had a rapidly escalating troponin. This was an example of her ECG. You can see that she has some pretty significant derangements in her ST segments. This is what's called a STEMI, or an ST elevation myocardial infarction or heart attack. And so this is a cardiac emergency. A STEMI often suggests a 100% blockage in a coronary artery. This is a big issue because it means that part of the heart muscle is not receiving oxygen, and you're at risk of having a good portion of the heart muscle die. The blockage in the blood vessel could be due to a number of causes, including an acute formation of a blood clot that's blocking flow, actually spastic closure of the blood vessel, or what's called plaque rupture, so where you have cholesterol buildup and it bursts into the lumen of the blood vessel. Patients will often present with crushing chest pain or pressure, trouble breathing, sweating, nausea, or in this case, with cardiac arrest. And we typically diagnose this based on the ECG and also patient symptoms. Cocaine and also methamphetamine have been related to heart attacks. So there's a well-known association between these in the sense that we know that stimulants can accelerate underlying heart disease. On top of that, stimulants are known to cause acute spasm of the vessel, which you can see in the photo on the right, where the caliber of the vessel just kind of clamps down and impairs blood flow. In addition, cocaine especially induces platelet aggregation or clot formation, and so this can cause complete 100% occlusion of the blood vessel, and that can be a really serious problem and cause pretty large heart attacks. And I want to just highlight that stimulant use does not need to be chronic in order to precipitate a cardiac event like this, and so to always have this in the back of your mind. Going back to our patient, she was emergently taken to the cath lab, where this is where we both definitively diagnose and also treat heart attacks. And so through a catheter that is put into the heart, you can see that they are injecting contrast, and they can see a pretty significant blockage in one of her main coronary arteries, denoted by that yellow arrow. The treatment is to open the blood vessel as urgently as possible, typically within 90 minutes, and to often place a stent to hold open that portion of the blood vessel. When you see these patients after they leave the hospital and after they've been treated for a heart attack, I just want to highlight it's really important that as much as possible, we support patients in continuing their medications to keep this fresh stent open. These things include dual antiplatelet therapy, which is aspirin and often clopidogrel. Moving on to our third case, this is a 34-year-old woman with history of hypothyroidism and stimulant use disorder, otherwise in her normal state of health. She is found in her car after a night out with friends. She's noted to have slurred speech, a left-sided facial droop, and left-sided body weakness. Her heart rate is 40. She's got otherwise normal vital signs. She is intubated in her apartment by EMS. When she's brought to the hospital, her urine drug screen is positive for methamphetamine, alcohol, and cannabinoids. So recognizing a stroke is really the important part that I wanted to highlight in this case. Stimulants can cause strokes through a variety of mechanisms, both the clot formation and also the very elevated blood pressure. If it's a clot, we call that an ischemic stroke. If it's due to really high blood pressure that actually ruptures one of the blood vessels in the brain, we typically call that a hemorrhagic stroke. And so these are both things that can be very life-threatening and very life-altering. And so to spot a stroke, I just want to remind people to look for facial drooping, arm or leg weakness, difficulty with speech. And if you see any of these things, which our patient actually had all three of these, it's time to call 911. Like I mentioned, stroke and stimulant use are definitely associated with one another. The main mechanism is probably through raising blood pressure. And when they've looked at retrospective studies, people who use stimulants have a much higher odds ratio of both ischemic and hemorrhagic strokes. And interestingly, women have an even higher risk than men. The thought is that their risk of hemorrhagic stroke is so much higher because women are more likely to have aneurysms or abnormal blood vessels in the brain that may predispose them to rupture when they have elevated blood pressure. This was a picture of our patient's head CT. You can see that that white circle in the middle of the brain, that is fresh blood that is bleeding into the brain parenchyma itself. She was diagnosed with a right-sided intraparenchymal hemorrhage due to a ruptured AVM. She required emergent brain surgery, and she ultimately did okay and survived to hospital discharge, where she actually was able to go to inpatient rehab and regain some of her strength in her body. Moving on to the fourth case, this is a 35-year-old man with fentanyl and methamphetamine use disorder, hypertension, HIV, and heart failure, who presents to the emergency room with tearing chest pain that radiates to his back shortly after using methamphetamine. You can see that his blood pressure is extremely high, 220/110. He's tachycardic. He looks extremely uncomfortable. He's sweating, his pupils are dilated, and he has a very rapid pulse. He's taken to the hospital, and you can see that on his CT scan, he has what looks like a little flap inside his aorta. You can see this in both the coronal and the axial views of his aorta, and that linear line that you see through there is abnormal and should not be present. That flap is consistent with what's called an aortic dissection. This is when the blood pressure is so high that it can actually cause a tear inside the wall of the blood vessel, and actually create blood can then enter that tear and propagate down the course of the blood vessel, creating what's called a false lumen. This can cause stroke, this can cause end organ damage and loss of limbs, depending on which blood vessels and branches are then compromised by this tearing blood vessel. And so this is also like a very serious complication that sometimes we can see with stimulant use. I show the picture on the right just to show that this can happen in a variety of different locations, and the classification is different depending on where the tear happens and how extensively it propagates. The treatment for an aortic dissection is aggressive blood pressure control, and then, if needed, repairing that segment of the blood vessel, either endovascularly, meaning just through using catheters through the blood vessels, or sometimes with surgical or open heart surgery kind of repair. So just a quick review of the life-threatening emergencies that I want everyone to be aware of. The first one is cardiac arrest and drug overdose. So if people are unresponsive, not able to speak to you, they don't appear to be breathing, and they don't have a pulse, call 911 and start CPR as soon as you can. If you're concerned that someone has a stroke, time is brain, and so make sure that you also call 911 to get that person to the nearest hospital. A heart attack typically presents with chest pain or shortness of breath. Sometimes in women, it presents more as nausea. So if there's any concern for a heart attack, to call 911 to try and get that blood vessel opened as soon as possible. And then an aortic dissection, particularly when people have more of like a tearing kind of chest pain or back pain, and often associated with a really high blood pressure. So moving on to our next objective. So we've reviewed the cardiac emergencies, and we're now moving on to more chronic cardiac diseases that are associated with methamphetamine use. The two things that I really wanted to highlight were heart failure and pulmonary arterial hypertension. These are two pathologies that we actually see quite a bit in our patient population. And so I just want to make sure that everybody knows how to kind of recognize maybe the early signs and symptoms of this so that patients can be appropriately referred. So what is heart failure? Heart failure is a problem with how the heart pumps. Heart failure is not a great term. I think heart dysfunction is maybe more of an accurate term, and oftentimes patients get really worried when they hear the word failure and are think that they are, that they're actively dying, which is not typically the case. This is typically a chronic condition that we can manage with medicines, and so I think sometimes just using different terminology like heart dysfunction can help people understand and wrap their head around what is actually going on. There's two different flavors of heart failure or dysfunction. The first one is HFrEF, or reduced ejection fraction. This is when the heart can't pump well. So the squeezing function and the ability of the heart to eject blood is compromised. There's also a second type of heart failure called preserved ejection fraction, or HFpEF. And this is where the heart has trouble relaxing or filling with blood. If you've ever tried to blow up like a stiff or a new balloon for the first time, it can take a lot of pressure and a lot of force because the walls of the balloon are so stiff. And that's essentially what HFpEF is. And so both of these can result from methamphetamine use in particular. And so these are things that I want to add to everyone's radar. The symptoms of heart failure typically involve swelling of the ankles and feet, trouble breathing when they lay down. So a lot of people will have to sleep on 4 or 5 pillows or sleep upright in an armchair as opposed to laying in bed. And then also progressive shortness of breath. So shortness of breath that starts with, I can't walk up hills anymore, to suddenly I'm having a hard time walking on flat ground, to even shortness of breath at rest. People may also report some of these other symptoms like fatigue, rapid weight gain, feeling lightheaded, irregular fast heart rate. And so all of these are things to kind of keep in the back of your mind. Common causes include heart disease, heart attacks, diabetes, high blood pressure, and heart rhythm disorders. In our patients who use stimulant use, these traditional risk factors are typically not as prominent as in a non-stimulant using population. But I just wanted to highlight that methamphetamine does cause accelerated heart disease. We talked about how it can cause heart attacks, and methamphetamine in and of itself is a direct toxin to the heart cells. And so through multiple mechanisms can cause heart failure. So like I was just mentioning, meth is a direct toxin to the heart muscle cells in the same way that alcohol is, and can cause cardiomyopathy or weakening of the heart function over time. In addition, through that sympathetic mechanism, high blood pressure, chronically elevated heart rate are also hemodynamic changes that put chronic stress on the heart and can over time compromise the function. Typically, this condition affects the left side of the heart, and sometimes it affects both the left and the right ventricles. And so this is an example of an ultrasound of someone with methamphetamine-associated heart failure, and you can see that both the left ventricle and the right ventricle are not squeezing well. And so this is an example of someone with heart failure with reduced ejection fraction. So if you suspect that someone might have meth-associated heart failure, you should, if possible, do a basic vitals and a physical exam. If someone has a lot of swelling, or if they're giving you in their history that they are having a lot of trouble breathing, this heart failure should go up on your differential. The next step is to decide if a patient needs hospital level care. And so if someone is got really low oxygen, or just having a lot of trouble breathing, even just at rest, if someone's got low blood pressure or really fast heart rate, if someone has really tense legs, meaning lots of swelling, sometimes fluid even can weep directly through the skin, or if you're worried that their legs are swollen and infected, or lastly, if people are seeing, say, one of their doctors in clinic, and they're getting kind of treatment as an outpatient, but things are still getting worse, these are all reasons to send someone to the emergency department for more rapid treatment and stabilization. If, however, people do not meet indication to necessarily need to go to the hospital right now, I think it's very reasonable to order an ultrasound of their heart to check some basic labs. Consider starting a diuretic. That's a medicine that makes people urinate more in an effort to try and remove the extra fluid that their body is holding on to in order to make them more comfortable, and then refer them to see a cardiologist for further management. The great news about meth-associated heart failure is that it is reversible for a lot of patients. And so I think it's really important to let our patients know that heart dysfunction or heart failure can feel really symptomatic, and it can require that people are in and out of the hospital quite frequently. And so it's definitely not fun and affects quality of life in a pretty significant way. And so I think just telling our patients that if they're able to cut back even just a little bit, that can really help their heart function improve over the long term. Methamphetamine cessation is obviously the best. It takes away the sympathetic drive and the toxic exposure to the heart, but that's not feasible for all of our patients. And so I think just supporting people where they're at and making sure that they understand kind of the cause of their heart failure and maybe how things are contributing. Diuretics, like I mentioned before, are primarily for symptom management and helping reduce going to the hospital. These, I just listed a few medicines in case, you're trying to recognize what medicines some of your patients might be on. And then I put a star next to guideline-directed medical therapy because this is one of the most exciting treatments that we have for methamphetamine-associated heart failure. We know from a lot of really large trials of heart failure in general that these medicines can help improve survival and reduce symptoms of heart failure and make people feel a lot better. There are 4 classes of these medicines, and this is what cardiology will try and get our patients on to help keep them out of the hospital and live longer. So this is independent of ongoing stimulant use. And so even in patients who are not ready to cut back or stop using methamphetamine, we still encourage people to get on guideline-directed medical therapy. And we have seen people recover their heart function just with medication alone. So this is a really exciting treatment to be able to offer our patients. We know from various studies, this one's from Germany, that in people who were able to stop methamphetamine use altogether, you can see that this graph in the upper left shows that patients were able to improve their heart function or ejection fraction pretty significantly. The lower left graph shows that people's hearts started out really enlarged and dilated, which is abnormal, and they were actually able to shrink their hearts back down closer to a normal size with discontinued use. And this is compared to patients who continued to use, where you can see that there wasn't too much change in either the size or the function of their heart. Additionally, in addition to improvement that we can see by ultrasound, patients also endorsed in this study having less heart failure symptoms, and they had lower risk of death and rehospitalization from heart failure if they were able to stop using. So the biggest message I want to get through is that if you have a patient that you're worried might have heart failure or any complication from substance use, I think a referral to general cardiology is very appropriate. I just listed the 4 of us here. I know that everyone here is outside of the UW Harborview system, but just to illustrate that these are 4 cardiologists at Harborview who have all expressed a really strong interest in treating patients with heart disease and addiction. And so I think that the interest, even within cardiology, in treating meth-associated heart failure is growing. It's being more recognized. And so no matter what health system you're in, I think more and more cardiologists are becoming equipped to treat meth-associated heart failure. I also wanted to highlight a program that is just a few years old out of Harborview. It's called the Community Heart Failure Program. We noticed that a lot of patients with advanced heart failure were being frequently admitted to the hospital, and they were having difficulty coming to clinic. And so instead of coming to clinic, they were just being rehospitalized over and over again. And every time we saw them in the hospital, their hearts were a little bit worse than before. So we really saw this need to address heart failure care out in our communities. A lot of our patients face a lot of adverse social determinants of health, things like unstable housing, lack of transportation, mental health and substance use disorders that I think make it very hard to come to clinic. So I think that this is a program that we've shown has been very successful in outreaching a lot of our most vulnerable patients. This is a picture of some of the people on our team. We have a nurse practitioner, a couple cardiologists, a pharmacist, and a patient care coordinator. And that's a picture of our UCAR. We go out Monday through Friday and meet patients where they would prefer to receive their care, whether that's on the streets, in subsidized housing, at shelters. We will find patients wherever they are and help bring heart failure care to them. These things include medications, so we'll pick up the medicines, we can fill Medisets, we can help with care coordination. We actually have the capacity to draw labs, to bring a portable ultrasound machine, to do a 12-lead ECG, and to provide a lot of heart failure education. And we are now trying to work through, collaboration with some of our addiction medicine colleagues in terms of how we can also help connect some of these patients with addiction medicine services as well. And so I think this is a really exciting care-based model that I hope will be emulated across the state and across the country to help outreach even more patients. Just some preliminary data. We looked at the first 10 patients who were enrolled in the community heart failure program. They each served as kind of their own control. So we looked at the number of ER visits and hospitalizations in the 1 and 2 years before enrollment in community heart failure. You can see that some patients had many presentations to the acute care setting. And then the yellow box highlights the number of presentations after enrollment in community heart failure. And you can see that we drastically were able to reduce hospital admissions and ER visits for heart failure. We showed that patients had higher engagement in care, including patients who had never successfully been able to show up for a clinic appointment. This is now expanded to be a full-time program that sees patients 5 days a week, and we now serve over 80 patients in our community. Similar to the paper I showed you from before, we have shown that some of our participants in the community heart failure program are able to recover their heart function over time, and this is despite ongoing methamphetamine use. And so this is just with patient education and getting patients on the right heart medications. And so this is a really exciting area and something that I want to continue to share with people all over the country. Just because people are still using stimulants does not mean that we shouldn't aggressively treat their heart disease as well. Pivoting quickly over to pulmonary arterial hypertension. This is due to abnormal blood vessels in the lungs, and this can put a lot of strain on the right ventricle. That's the part of the heart that actually pumps blood to the lungs to pick up oxygen. You can see that if there's disease in those pulmonary arteries, it can make it much harder for the right ventricle to pump blood forward into the lungs. Methamphetamine causes this vascular obstruction through a variety of mechanisms, but it can cause hypertrophy or thickening of the muscle inside the blood vessel wall, in addition to kind of chronic remodeling and fibrosis of the blood vessels that makes them very stiff. And so this is how it causes elevated pressures in the lungs and sometimes right ventricular heart failure. You should suspect pulmonary hypertension if, again, patients are presenting with progressive shortness of breath, particularly with activity or just kind of general out of proportion levels of fatigue. When cases get more severe, they also will start presenting more with classic heart failure symptoms like swelling in the legs, fluid retention in the abdomen, decreased appetite, exertional chest pain, and sometimes even fainting. Again, the workup for this is physical exam and a thorough history, to order a transthoracic echocardiogram, and to refer to either general cardiology or general pulmonology. There are 5 different classes or groups of pulmonary hypertension. Methamphetamine falls into the first group. And so even though in the general population, group 1 pulmonary hypertension is very rare, this is actually something that we see quite frequently in our patient population who use methamphetamine. This is diagnosed or confirmed with an invasive test called a right heart catheterization, and this is where we're directly measuring the pressures inside the lungs and the heart to confirm that we are dealing with this first group of pulmonary hypertension. If that's confirmed, there is treatment for pulmonary arterial hypertension. There's a variety of pulmonary vasodilator medicines that relax the blood vessels in the lungs and improve blood flow. The treatment is very similar to heart failure in the sense that if patients are able or ready to either cut back or completely stop using methamphetamine, that is preferred and is really important in trying to halt further disease progression. But in the same way that us in cardiology support patients, even with continued use, patients can get pulmonary vasodilators, even if they're still using methamphetamine. We have a special clinic at the University of Washington that treats group 1 pulmonary arterial hypertension. Those are the pictures of the 4 providers that we have there. And so generally the correct step is to start with general pulm or general cardiology first. But if someone really needs and is confirmed to have PAH and needs these specialized therapies, we do have a more specialized clinic for these patients. So that was a rapid review of kind of the chronic cardiac diseases, namely heart failure and pulmonary hypertension that are associated with methamphetamine. The last part, I just want to promote that this is a really complex, the stimulant use is a very complex medical condition that requires a lot of interdisciplinary care from a variety of specialists. This is not an exhaustive list. My Venn diagram just was getting very full, but there are so many people who provide really important support, not just medical, but non-medical folks as well. And I think that we're all a big team in trying to find ways to connect and support these patients and get them the resources that they need to address their health. I just want to put a plug in for trauma-informed care. I think it's really important that we connect with our patients and really understand their lived experience and how trauma has played a really significant role in that, and directly influences the way that they interact with the healthcare system. I think it's important to reflect on our own subconscious biases and to really try and treat substance use disorder as a chronic medical condition, just as you would heart disease or lung disease. I think it's helpful too to try and understand why people use. I think this helps address not only how we can help best support patients, but also builds a lot of empathy for what people have experienced and gone through. And so I always like to ask that and just find ways that, especially if there's anything reversible that I could help with, I think it's just really helpful. And people really appreciate when you ask. And then to just always be assessing readiness for change. I think particularly when people have had a medical emergency or have chronic disease that is known and related to stimulant use, I think people, this is a dynamic process, and people may be ready to change on some days more than others. And I think just being there for people wherever in the stage of change they are, and realizing that cessation is not always a realistic goal for our patients, and that that's okay, and that we will treat their heart condition and we will treat their lung condition regardless of where they are on this spectrum of change. I think if people are in the beginning, you know, all of the great work that everybody on this chat does in terms of harm reduction is really important. I think if people are farther along on the stages of change, then getting them connected with addiction medicine can be really powerful. And then just to highlight that even though we don't have pharmacologic treatments that are super targeted for stimulant use disorder, we do have a lot of other tools in the toolbox, including contingency management, cognitive behavioral therapy, motivational interviewing, et cetera, that can be really effective for patients who are dealing with stimulant use disorder. So just to wrap up, the take-home points from this talk that I hope you will remember is that stimulant use is really a growing epidemic. Cardiovascular disease is very common and actually the second leading cause of death in people who use stimulants. Stimulants can cause a lot of life-threatening emergencies, including heart attack, stroke, cardiac arrest, and aortic dissection. Meth in particular can lead to a lot of chronic heart and lung conditions, such as heart failure and pulmonary arterial hypertension that require specialist and longitudinal care. Meth cessation and reduction can lead to improved outcomes and symptoms, but is not an achievable goal for everyone. And so just providing support whenever we can. And then providing empathetic, trauma-informed care for all of our patients. And then please refer your patients to cardiology, pulmonology, and I hope that more programs around the state and across the country will continue to crop up that maybe emulate some of the work that the Community Heart Failure Program is doing here. So I just wanted to thank Dr. Leidy, Jamie and Kate, and Dr. Yadava for their mentorship and their support, and for all of the people who are on this call. Thank you so much for your attention. Please reach out to me if you have any questions or if there's any way that we can collaborate in the future.